A quick disclosure, I do not get paid by any of the products or any of the services I mentioned in my presentation, although I wish I could, but well. Anyway, so going ahead, I work at the Department of Prosthodontics here, and I'm the clinical assistant professor along with a few other things. And a quick introduction about me is that I did my dental school from Indore, India, and the picture you can see on the top left is a place pretty close to Indore, and it's called Omkareshwar. And in fact, Indore has been voted as one of the cleanest cities in India. And yeah, once I was done with that, practiced there for a few years, and then I came to the University of Florida, where I did my residency in prosthodontics as well as my internship fellowship. And yeah, that's a little quick snippet about me. So now that you know me, let's go ahead and let's get started with the topic, because that is why you are here, right? So let's go ahead. And so the first question is, yeah, all of us hear a lot about digital, right? Digital this, digital that, everybody's doing digital. Um, the most important question that we need to ask before we get into it is why? Why do you want to go digital? Yes, I understand you want to go digital, you want to get into digital dentistry, that's exciting. But the most important question here is why? Get into it for the right reasons, right? Is it because you get, I don't know, good occlusion, or do you get precision? Is that it has better accuracy or fit or aesthetics? Um, well, frankly, we've been doing really good dentistry for the last 60, 80 years without digital dentistry, without chairside CAD CAM, without any of these systems. But we've still had really nice and aesthetic crowns, bridges, restorations. Patients have been happy. So is that the reason you want to get into digital dentistry? Not for me. For me, the main reason that I would get into digital dentistry would be predictability, right? Because every time you do pros or endo or anything in dentistry, predictability is the name of the game. You can send a particular crown, you can have a really nice lab, but there is no real guarantee that you can get the same quality or the same fit back from the lab every single time, right? However, um, with digital, that's a good thing, because with digital, because you have predictability, then you have consistency. Once you kind of understand every system, what's lacking, or what's the error with every system, and once you can kind of account for the system, that's where you can make your procedures a lot more consistent. For example, right, everybody's been using zirconia crowns for a long time now, right? Yeah, they get good fit. Did you know that zirconia actually contracts or shrinks about 30%, 33% when you fire it, when you sinter it? Yeah. And so what happens is, when you actually mill zirconia, you mill it to be about 33% larger than what you want its final size to be. Why? Because once you know that it's going to shrink or contract about 30%, that's when you know that the final crown after the sintering will fit the patient and will fit well, right? And that's what I mean by consistency, right? And predictability. So let's talk about a few applications of digital dentistry today, right? So there's a lot of things where you can use digital in dentistry today, right? There's diagnostics, there's computer guided surgery, there's crown and bridge, fixed work. You can do it with implants, digital dentures, and just so many things. So let me show you a few cases, right? What you can actually do, where it has kind of helped me with, with some of my cases, right? So for example, right, a while back, by the way, this case with a very good friend of mine, Fadi Farwati, amazing guy, dual trained, perio pros, amazing guy to work with, right? So this patient walks in the door and says, you know what, I have had these teeth for a long time and I don't like the way it looks. I don't know what's wrong, but I want it to start looking better. And it turns out this patient has really severe fibromatosis gingivae. It's a condition in which you have a lot of connective tissue. You have a lot of fibrous content in the gingiva. As a result, the teeth, right, they're either not able to erupt or they erupt in the wrong position. Okay. So the treatment plan for this patient was immediate dentures. After we talked to the patient, educated the patient about different treatment options, she went for immediate dentures. Okay. Now, conventionally, for immediate dentures, you would do, what? You would go ahead, take impressions, make your occlusal records, and basically, extract the teeth on the cast, and then set it, and then basically extract the teeth on the patient, and then deliver the dentures on the same day. However, in this case, the problem was first that you don't really know where the teeth are. Second, you don't know their relative position with the nerves, right? You don't know where to actually where to enter the bone to remove the teeth. And so a simple thing, right? A simple thing like a CBCT is really helpful in determining where the teeth were. So if you reduce the opacity of the bone a little bit, you can actually see where those teeth are. And once you know where those teeth are, you can actually go ahead and extract them. Additionally, in this case, what we did was, because we already took an impression of the patient in the first appointment, I could go ahead, superimpose that cast onto the CBCT and plan the dentures that way. So if you see, these are my casts. And I hope you can see my monitor, and I hope you can see the little mouse in there. Um, okay, so if you can see my mouse in here, you can see how we extracted the teeth on the cast, right?
Reduced. See it just fine.
Yeah, excellent. Thank you. So you can see how we extracted the teeth on the cast and reduced the tissues, right? Shaped everything up, shaped the bone up. And however, if you notice, I left tooth number 9 just in there. Why? Because number 9 was what gave me the reference of the incised edge, right? And according to that, I went ahead and placed the teeth, and yeah, the same thing with the mandibular as well. So once that was done, of course, with the help of a periodontist or a surgeon, um, we could go ahead extract all the teeth without any major issues. We could also make surgical guides for the patient, so we know where to reduce the bone, how much to reduce the bone, and yeah, these are the immediate dentures. Yeah. And once that was done, this was the tissue after it healed, and this was the immediate denture for the patient. Again, this was, could I have made this immediate denture better? Yes, 10 different thousand ways, However, was the patient happy? That's what really matters at the end of the day. Is the patient happy? The patient was ecstatic. The patient was very happy with the result. Later on, of course, we went ahead and made a new denture. But as you can see, we found this, we found the CBCT really helpful to see where the teeth were. Another application of this is in computer guided surgery and restoration, right? This is something that is the hot thing these days. So we had this patient, as you can see, right? When she smiles, we can see her alveolar ridge. And that basically, every time I see this, I know that, okay, in case the patient wants to go for something fixed, like a hybrid or something, I might need to reduce bone. And so once we made dentures for this patient, right, we went ahead and, planned the implants accordingly. Once that was done, a surgical guide was made. Now, keep in mind, this was done maybe about 2016, 17-ish, I'm thinking. And that was because that was even before the concept of smile in a box, came out. And this was a 2-part guide. So we planned the whole guide, and we split the STL file into 2 pieces, wherein this piece fits on top of this piece, right? And the whole thing looks like this. So once the base goes onto the tissues and the bone, I know how much of the bone to reduce, Once the bone is reduced, right, I can go ahead, place this part of the guide onto this part, right? And I can go ahead, place my implants. So this is what the case was. Once we opened the gingiva up, keep in mind, this here, right here, was the floor of the mouth. This was the bone. You go ahead, reflect that, and after the bone reduction guide was placed and the bone was reduced, you can see how much bone actually we could reduce predictability, predictably, without hitting the bone, right? Now, every time I see this picture, it's just a beautiful thing. You can see the genioglossus muscles, the mylohyoid. It's just a wonderful thing. Anyway, getting back to topic. So this was how much bone we had to reduce so that you have enough room for the prosthesis, right? Now, different prostheses need different, amount of space. And again, that's a different topic for a different time. But yeah, we went ahead, placed the guide, immediately loaded both the upper and the lower. And once that was done, healing was done, the patient was comfortable, we knew that the occlusion was good. We planned a framework in chromium cobalt and tried it in, made sure it was nice and passive, right? And we went ahead and basically stacked some porcelain on there, layered some porcelain. And the good thing was that since the patient was a bruxer, we knew that there might be, issues with patient breaking some crowns. And so we wanted the crowns to be separate. And so we could mill Emax crowns on top of the framework. And this was how the patient looked after the whole treatment. Again, this was another application, right? Now, the most common thing that we see people using CAD-CAM these days is chairside CAD-CAM for crowns, bridges, and again, for that, you have a lot of systems. My journey with CAD-CAM started with the Blue Cam, right? Then came the Omnicam, then the Prime Scan. Okay, now you have the Prime Scan, and it's an absolutely fabulous, fantastic machine. Again, it's not just that, there are just so many more systems, right? You have, I don't know, 3Shape, you have Lava, Strawman, Denver Wings, just a plethora of systems that you can actually use. However, essentially, all of them have this common, workflow one way or the other, right? Where you go ahead, do your preps, scan them, and once you're done scanning, you go ahead, trim the model. Either you do it manually or the software does it for you one way or the other. But that's essentially what you do. Once that's done, you go ahead and mark your margins. In this case, as you can see, I'm just going to go ahead and trim the cases, trim the teeth. Once that's done, I'm going to go ahead and mark the margins. Okay. And that is something that I like to spend most of my time on. Okay. It's marking the margins because at least with my experience with the Blue Cam and the Omnicam, you know, the margin of the crown is going to be where you mark it onto the tooth, right? Of course, I mean, I would love to try the Prime Scan. I haven't got the opportunity to try the Prime Scan yet, but I hear really good things about it. It has this AI system where, it can actually identify the margins for you. So, which is really good. But anyway, this was one case as well. With all of these cases, again, predictability is the main thing, right? Another thing is, you can use digital for things like virtual smile design. Now, this thing is not just for use as a prosthodontist, right? You can use this thing for patient communication. You can use this modality for lab communication, for treatment planning, right? For example, a while back we had this patient. Again, this patient had a lot of fractures, cracks going on in the teeth, and a lot of erosion, a lot of erosion. The guy worked with one of the major, national football teams, and just drank Powerade all day, all day. And yeah, eventually over the years ended up, getting a lot of attrition, chemical erosion on the teeth as well. And finally came into the clinic asking for, something better, something to improve the appearance, something to improve the function. Now, if you think about it, cases like this generally go for like full mouth rehabs, right? And in general, a full mouth rehab will cost anywhere upwards of $30,000, $50,000. I don't know. It can be different for different clinics. However, I mean, think about it. If you were to go ahead, right, and spend all of this money, right, it's almost equal to a car, right? Almost like buying a car. Think about it. Would you ever buy a car without actually looking at it? No, right? At least I wouldn't. I mean, I don't know. I haven't tried, I think it's like CarMax or Carvana or something. I don't know. But the thing is, I wouldn't buy a car. I wouldn't spend $50,000 without knowing what I'm going to get in return, without being able to see it. So what we did was I went ahead, made a few impressions, clicked a quick picture, put it into my computer, traced the midline for the patient, traced where the ideal occlusal plane, the incisal plane needs to be, put it in my computer, and just went ahead and overlapped my photo with my cast, the scan of the cast, and from there you go ahead and do your initial wax up, a quick wax up, just to show the patient what you have in mind. Once that's done, you can of course tweak your wax up, and then either print it, mill it, make temp shells. There's just a variety of things that you could do. Okay, now again, if you notice, I did this with Mesh Mixer. I didn't need a separate intraoral scanner. I didn't need any fancy software. I didn't need any fancy computer. Nothing, right? So Mesh Mixer is an open source software that you can actually use for all of these applications, right? Just that it has a lot more clicks. You just need to know what you're doing. And the more you play with it, the easier it gets. So anyway, I also do, like full mouth wax ups, and it's pretty easy. It's pretty much the way you would do it in a lab. You add wax, you remove wax, you smoothen out certain areas, make sure it fits well, also make sure that the occlusion is good. And of course, Mesh Mixer has its own limitations, and that's where the commercial softwares like Ceric in Lab or Exocad or other software, Strawman, that's where they shine because they simplify things for you. Now, for a person who's getting into digital dentistry, wants to take the first step into digital dentistry, the question is, okay, so where do I begin, right? Now, there's 1,000 things we can do. However, the first step, at least in my opinion, needs to be something that you can get your foot inside the door, right? That you can just, it's easy, right? So my recommendation would be to start with digital dentures, right? And why do I say that? Of course, you're not going to get uh, a lot of, from the beginning, until you get confident with it. You don't want to use digital or a new system basically with crowns, bridges, or any of the bigger cases. With the denture, of course, you have a lot of patience and a lot of cases to do, a lot of cases to practice on, a lot of cases to learn on. And of course, each case you do is a learning experience, right? And so right now, in the US, if you see, we have just so many patients that are completely edentulous, right? We have even more patients that are partially edentulous. They're missing either one tooth or they're missing the entire arch, right? In general, about 15% of those people who are completely dentulous have dentures made every year or need dentures every year. That amounts to about 5.4 million people. And that means about 10.8 million arches a year, right? So again, a lot of things, a lot of patients to do digital dentures on. And conventionally, talking about dentures, what we're being taught is, that always what you want is, three things, right? Your prosthesis needs to have form, function, and aesthetics, right? Once you have that, that is when you have a good prosthesis, right? However, when the patient comes in to the clinic, right, when the patient sits in your chair, you tell him form, function, aesthetics, he's not going to understand anything, right? What the patient is actually looking for is, first thing, that costs less, okay? Some treatment, something that is inexpensive, doesn't cost too much, something that looks good, and something that doesn't take too many appointments, right? So because of this gap, right? If you look at this gap between what we want to offer and what the patient wants, we need something in between. So what that needs is to think outside the box just a little bit. And that being said, let's see how we conventionally do dentures, right? So conventionally, to make a denture, what you need is, say, in the first appointment, you do your primary impressions. In the second appointment, you do the bone moldings and the final impression. The third one is the mandibular relations, maxillomandibular relations, and then you do your try-in just to make sure everything's okay, and you go ahead and then deliver, right? So basically, to get a denture, the patient has to come to you, to your clinic for at least about 5 times. So it's like 5 separate appointments, assuming you get everything right, everything done in the first appointment, right? And so at the end of the 5 appointments, the patient is getting tired, you're getting tired, the patient's getting frustrated, and by the end of it, all that the patient's getting is a set of dentures that the patient's not going to be, completely satisfied with in terms of function, in terms of, um, when the patient comes to you, he wants something that he can bite into stuff with, function just like natural teeth. And of course, given the dentures are not going to do that, right? It's just a different modality. It's a new learning curve for every patient. Um, but, at the end of it, there's a lot of frustration as well, right? If you think about it, if you look at this whole process, right, and you think about it just a little bit, you'll notice that in the first 2 appointments, all you're getting is information about the intaglio, right? In the second appointment, in the maxillomandibular relation, basically it's the third appointment, I'm sorry, all you're getting is information about the cameo surface, where the teeth need to be, where the neutral zone is, right? And once you have the information about the intaglio, about the cameo, that's when you go ahead and, set everything in, try in, and you do your delivery. What if I told you that you could get the same information in lesser number of appointments, right? So if you look at this workflow where you do a final impression on the first appointment with the patient, that's where you get your the information about the intaglio, right? On the second appointment, you do your maxillomandibular relations, right? And that also serves as a try-in because you set your teeth in. And once you have all of that information, you can go ahead, process the denture, and deliver it in just the third appointment. In fact, if you have enough information, you could also do it in 2 appointments, right? However, I'm not comfortable with that, at least as of now. And so I always want to do a try-in before I do my delivery. Maybe, I don't know, I just like doing that. And so for my workflows, I always add in a try-in into my whole process, right? And these 2 processes, right, is what digital dentistry offers you, or digital dentures basically offers you. So looking at, what options you have for digital dentures these days, there can be a lot of different options, okay? You have in the market, you have Avident, you have Denka, you have Blue Sky Bio, Ivoclar, Pala Digital Dentures. Although I think Pala Digital Dentures stopped their service on the 1st of March this year, I believe. Yeah. But anyway, you still have a lot of options, and essentially all of them need the same information. All the workflow at the end of it gathers the same information. The information about the intaglio, information about where the teeth need to be, that's the cameo surface. And, once you have all of that, you can go ahead and make the dentures, right? Now, essentially, if we want to learn something from our fellow industrialists from other industries, right? The main thing is to start with the end in mind, right? So just like the car industry, right? The first thing when they design a car is they place those 4 wheels, on the design table. And after that is when they actually design the whole car, right? So if you draw inspiration from that and actually think about it in some dental terms, right? So you have your cast, you have the patient, right? For example, now there's a lot of information that I can get from this cast, a lot of things. For example, I have the retromolar pad area, right? This tells me that the posterior border of the occlusal plane is going to be right there, right? Now, because you have the cast already, you know where what the intagliar surface is going to be, and for the cameo, you know that the posterior extent of the occlusal plane needs to be at 2/3 the height of the retromolar pad, right? So once you extend it from there, the only point you want to assess or try to know is the anterior point, right, of the occlusal plane. So if you look at it from the front, this is how the occlusal plane is going to be, right? And at this point, it's just a guess, right? But that's where you want your 8 and 9 to be, right? But again, this is at this point just a guess. And so that's why, right, in the patient, that is the point that you want to be looking for. Okay, because all other information about the denture you can get from the impression. The only thing that you cannot get from the impression, right, is that point. Okay, and that's what I call the Z point, is basically a point where the incisal plane intersects the midline of the patient, right? So again, it'd be any system, right? Whether it be the Ivoclar or Avident or Denka or any system, all of them at the end of the whole thing, they want this information. They need you to tell them where the incisal edge needs to be, where the midline needs to be, where the teeth need to be, as in the sense, you know, where the neutral zone needs to be, the vertical dimension of occlusion, right? Lip support, the centric relation, and the tooth size and tooth shape, or basically the tooth mold that you want to use. If you want to look at it another way, right, if this is the final product that you want to deliver, the denture, right, this is what you want to ascertain before you go ahead, right? So it's the point where the midline meets the occlusal or the incisal plane, right? Now, there have been a lot of studies about this, right? For example, you know, there's been studies by Ellinger, there's been studies by Solomon. A lot of people have studied this, and now we have a basic average about, you know, where you want the incisal edge to be based on certain anatomical points on the ridge or on the palate, for example. You have the incisal or the incisive papilla, right? We know that ideally the position of the incisors need to be, or the incisal edge needs to be about 7 to 9 millimeters anterior to that point, right? That's my horizontal reference. And for the vertical reference, I use the length of the lip, right? For example, for female, I will go ahead and place my incisal edge about, say, 1 to 2 millimeters below. But for a male patient, I would go ahead and place it almost at the level of the lips, right? Again, this is a little subjective, but basically you are placing the incisal edge of your denture approximately in that area, right? And once you try to get closer to the final position, right, the whole puzzle of the denture starts, you know, getting into place, okay? And eventually you go ahead and you're able to deliver a good denture to the patient, okay? Now, I know this is a lot of information, okay? And we went over it really fast and really quick, but now I'm going to tell you, you know, different scenarios, right? So basically with complete dentures, you can have just two basic scenarios, right? Um, Either the patient has a pre-existing denture or the patient does not, right? So let's look at scenario one where the patient does not have pre-existing dentures or no previous dentures, right? In this case, you have a lot of options. There's many workflows that you can do, right? You could use your traditional wax rims, you could use something called the AMD, or you could use the Wagner Easy protocol. Okay, so once you do your initial impressions, you could either go ahead, make a custom tray, do your final impressions, make your wax rims on record basis, make sure everything is good, right? The VDO, VDR, where the incisal edge needs to be, adjust the maxillary, mandibular, occlusal rims to that point, and make your markings, get a good CR, and get that done, right? Um, Another option is you could use the AMD or the anatomical measuring device, right? Now, personally, in my hands, I don't like to use this system, but you're welcome to use it. See if it works in your hands. There's just many ways to do a particular thing, especially in pros. That's what we say. There's many ways to skin a cat. But yeah, I mean, this is basically a device, almost like a central bearing pin device, where you adjust the pin to the patient's vertical dimension of occlusion, make sure that you get a good centric, and once you get a good centric record, go ahead, stick the teeth in there, make sure that the patient likes it. It's basically a sticker that you can stick in there. So basically, that tells you where the midline is and where the incisor edge needs to be. Based on that, you can go ahead and do the trying, right? However, my personal favorite technique is the Wagner Easy protocol, right? And we'll talk more about it. The thing is, doesn't matter what protocol you follow, okay? After you do your records, all of this information goes to the lab, right? And they are able to make you a trine, a milled trine, right? And this is what the trine basically looks like. Everything is printed or milled, right? And this is just like a trial denture, okay? If there's any adjustments you want to make, you can go ahead, mark where you want the midline to be, with the marker or a pen, and you can also go ahead, adjust the occlusal plane a little bit, adjust the vertical dimension, just like you would do for like regular dentures, right? Once that's done, you send that back to the lab, tell them, okay, I like this, I like the intaglio, this is where the midline needs to be, this is where the vertical needs to be, this is how the occlusion is, and the company goes ahead and makes you a set of final dentures. And you can see that, once you do your adjustments, it replicates those adjustments in your final dentures, makes those adjustments, and gives you a really good product or a really good denture, right? I've been personally really happy with it. So let's talk about the Wagner Trine protocol, right? If you go onto Avident's website and check out the protocol that they publish, this is basically what you'll find on there, right? So this concept or this protocol was introduced by Dr. Stephen Wagner, and basically it's a 3-appointment denture, okay? What you do is you use thermoplastic trays, okay? You put it in water that's heated to about 160 Fahrenheit for about 1 minute. What I do is I just heat it really nice and hot. I don't care if it goes above 160. That way, I don't need to put it in for 1 minute, right? I can just put it for 10 seconds or 15 seconds. But anyway, once you're done, you go ahead, make sure it's nice and soft, put it in the patient's mouth, have the patient do board molding movements, okay? And so when you take it out, go ahead and evaluate the trays, okay? In some areas, you might need to adjust. Once the tray cools down, you can also trim it with a burr, or as long as it's nice and soft, you can go ahead and cut it with a scissor, a surgical scissor, doesn't matter, right? But anyway, one way or the other, right? Whatever way suits you, you go ahead, adjust the trays, make sure everything is nice and good, that the trays do not rock, it's nice and stable, even during board molding movements. And yeah, from there you go ahead, do your board molding with PVS. I use generally a heavy body PVS for my first layer. Of course, once on the border, and I also place a little bit in the center, just to function as a little bit of spacer, because I want to ideally keep about 2 millimeters to 3 millimeters of space for PVS, right? The same thing you do for the upper and the lower as well. Once that's done, what you'll notice is that there are some areas of burnout. Okay, that's where the tray is touching the ridge. That's where it's touching the tissues. You don't want that. You want a little bit of space. You want a little bit of room for the final impression material to go in, set, and be dimensionally stable. Okay, and so you go ahead and those specific areas of show through, you can take a burr to it and reduce those areas, create a little bit more of room in there, and again, wash it with wash consistency PVS, a light body, anything that suits you. Okay. Now, conventionally, if you look at it, we've been taught to do our border moldings and, with green stick compound, right? So I get a lot of people saying, you know what, I'm not comfortable doing PVS. I'm comfortable doing green stick compound. And that's completely okay. That's not a problem. Okay. In fact, if you look at a study by Drago, in 2013, um, what he did was he examined about 156 patients. Now, half of these, the border molding was done with PVS, and half of them it was done with the green stick compound, right? And they assessed both dentures post delivery, saw how many appointments or how many adjustments did the dentures actually need, if it was done with PVS or it was done with green stick. What they found out was that there was no significant difference between border molding done by PVS or green stick. So any way works, right? As long as you get good borders, that's what matters. Doesn't matter you use green stick or you use PVS. Okay, just make sure at the end of it all you get a good final impression. That's what matters. Okay, now this is the first phase of the first appointment. The second thing is really easy as well. All you need to do is you need to go ahead, locate the incisive papilla, right? Once that's done, use the papillometer, or they call it the avometer with Avnet, right? Place it on there, okay? Ask the patient to relax his lips, record that measurement, and keeping the papillometer right there, ask the patient to go ahead and smile, okay? That way, this tells you, how much movement or how much motion is there in the tooth, and how much display are you going to get, right, with the lip, okay? And that gives Avident or the lab the basic idea of, okay, how high or how tall you want to keep the teeth, okay? Once that's done, just two more measurements, right? You need to do the interalar width, okay? Measure the distance between both the alas and measure the distance between both the interpupillary and between both pupils of the eyes, right? So these are just the four measurements you need in the first appointment. The lip length at rest, lip length at smile, right? The interalar and the interpupillary measurement, okay? Once that's done, record all of that on a form, select your teeth. Yes, this is the first appointment, and you select your teeth and the mold and the shade on the first appointment, okay? You take all this information, send it to Avident, and wait about a week or two, this is what they send you back, okay? This is called the Wagner trine, or the anterior 6 trine, okay? So what this has is the posterior teeth on the upper is basically printed and connected with the base, okay? The, it has about 6 or 8 teeth set on the maxillary and 6 teeth on the lower anterior set as well, with a occlusal rim in the posteriors. And once you go ahead, place it in, right? What I do is I always place my upper in place first, adjust the incisors if I need to, adjust the midline, make sure my incisal edge is in a good place, make sure my midline is in a good place, make sure that the patient can speak well, make sure that the patient can function well, make sure that the fit is really good, okay? I adjust my lip support if needed, adjust everything that you would do in a maxillomandibular relation record appointment and a trine appointment, right? Because it's essentially that same information, okay? This is giving the lab the idea of the cameo surface of the dentures, right? So you go ahead, adjust all of this, make sure that everything is good, patient is happy, patient can function well, patient can bite well, speak well, smile well. And once the patient sees the teeth in place, that can also function as a try-in. So ideally, you don't need to do a separate try-in after this is done, okay? Because once the final dentures are done, it's exactly the same thing that it basically replicates the whole adjustments that you've done. Okay. So anyway, once you've done all your adjustments in this stage, you go ahead, record a centric relation record. Okay. Now there's multiple ways of doing that. You can use either by manual manipulation, or you could, do just a physiologic method when, you could have the patient curl the tongue back, or you can do a chin point guidance. There's just multiple ways, any way that you are comfortable with. Okay. That's what matters. What matters is that you get a good centric relation record. Okay. Doesn't matter how you get it. All that matters is you get a good record. Okay. Me personally, I have the patient curl the tongue back and I just gently touch the chin. Okay. I don't push it. I don't protrude the jaw. I don't do any of that sort. I just keep my finger right on here, okay, on the chin, and ask the patient to curl the tongue back. Make sure you notice the condyles drop. Make sure you notice the jaw drop back in place, okay, and then have the patient bite down at the right video, okay. Once that's done, you can send it to the lab. A lot of times, you can also, if you're not comfortable with that, you can also do one of my cases. I did a hybrid method, right, where I did a Wagner try on the top, and I did conventional wax rim on the bottom, okay, just to see if it makes any difference. And guess what? No difference. It was just as predictable. Okay. So this was the try-in that we got back for the patient. I went ahead, seated my try-in, and made any adjustments that I wanted to make. I adjusted the midline, made sure that the patient was happy. Okay. Once that's done, make sure that you get patient approval. Okay. Make sure that the patient is happy. Let the patient know that, okay, this is how the final is going to be like. This is how it's going to fit. This is how it's going to feel like. Make sure you can speak well, make sure you can function well. And if you want, we can go ahead and process this in final denture, right? Make sure you get that patient approval and document it, okay? CYA. Make sure you cover your abutments, okay? Once that's done, of course, the whole record goes to the lab, and they basically mill you a set of dentures. Now, for this particular patient, this is the dentures I got back, and I tried it in, made sure that the fit was good, used PIP, both for the upper, for the lower. Once the fit was good, you go ahead and check the occlusion, make sure that the occlusion is nice and even. In most cases, it's pretty right on, okay? But a lot of times you might need to do a little bit of adjustment here and there, and that's okay. You need to do that with any dentures, right? But yeah, this is what we got back, and this was the patient, right? He was particularly really happy with the dentures. And the best part that he was happy about was that the whole thing just took 3 appointments, right? Just 3 appointments. And the third appointment was the delivery. The third appointment was where he got the dentures, right? So he was really happy about that. And again, we've done a lot of cases like these just with this method alone, right? And of course, I've had a team with me working, and it has worked well in almost everybody's hands, okay? So a lot of patients have been happy and, satisfied with this technique. So, naturally, I've been really happy with this as well. Going forward, okay, the scenario 2 is when the patient has existing dentures. As in this case, right, this patient came to me saying basically his initial denture was fractured. What I did was, just go ahead, grab some glue, stick it back together, put it in, and assess it for, different parameters, and we'll talk about it. So basically, the thing with this patient was that he said, I want a new denture. The thing is, I want it to look exactly the same. I was like, no, you know what? I can do this better. This can be done. They're like, no, 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 no. You don't understand. I need it to look exactly the same. Turns out he works in the, the film industry. And so he was working on a project and he couldn't afford the teeth looking different in the first half of the movie and then the other half of the movie. Anyway, so basically, he wanted the final dentures to look exactly the same. So this is where you use a protocol called the reference denture protocol. Okay, so you go ahead, make sure that the lip support of the denture is good, the midline is good, the incisal plane, occlusal plane, all of that is doing good. And once you notice that, okay, this is what we want. Okay, go ahead and you know um, do your final impression. You could either do it in the existing denture, or what you could do is you could also duplicate the denture in a line duplicator and use that as a custom tray. Me, I just use the patient's existing denture as a custom tray, and just do a quick wash impression with that. And we have a scanner, so all I do is once I'm done with both the impressions for the upper and the lower, I take a quick bite record and scan it. Within an hour, it's scanned. The dentures are cleaned. I take out all of my impression material from the teeth, from the dentures, and give the patient the dentures back again, right? That way, the patient doesn't need to be without his or her dentures. And the whole process is much easier. I have my records, and the patient doesn't have to be without the dentures. Okay, so just as I said, you go ahead, make your final impression. Again, once you put your final impression material in there, doesn't matter what it is. It could be PBS, polysulfide, anything that works in your hands. Okay, as long as it's scannable, it's okay to use it. Okay, so as in this case, right, you can see I use PVS, right? Bottom molded it with the green heavy body, and then did a light wash with the yellow. I was in this case, I think, using Aquasil. So yeah, every time you put a little bit of material, generally there's an increase of VDO. Make sure you go ahead and adjust that. So you might need to reduce it from the occlusal surface of the teeth, as long as you can communicate to the lab where the occlusal plane needs to be, where the vertical dimension of occlusion needs to be, where the midline needs to be. Uh, that's what's more important. Okay, this part does not need to look like the final dentures, right? And you'll see my teeth are flat, right? That's because I reduced them. Because once you put material, there's an increase in VDO. So go ahead, make your adjustments. If you need to add, you can always add wax or composite, doesn't matter. If you need to change the midline, go ahead, grab a marker, grab a pen, mark the midline, okay? Mark where the ideal midline needs to be. Once that's done, send this whole record to the lab, either physically, you can mail them, or you can just scan them using a desktop scanner. That's what we have here in the department. And once that's done, the lab basically gives you, a try-in, okay? However, before you do that, make sure you obtain patient approval. Again, CYA protocol, cover your abutments, right? Anyway, once that's done, go ahead, send it to the lab. The lab scans it, so that way you have the intaglio surface information with the information from the duplicates of the dentures or the scan of the dentures. You also have an idea of where the occlusal plane needs to be, where the centric relation, where the occlusion needs to be. Once that is there, all that the lab needs to do is connect both areas, right? Trim the margins, make sure it's nice and smooth, right? And basically, this is what you get back from the lab, okay? Again, at this stage, this is your second appointment with the patient, okay? You go ahead, try that in, okay? Again, verify all those things, okay? The same set of 6 things: incisal edge, midline, centric relation, vertical dimension of occlusion, vertical dimension at rest, right? Position of the teeth. Can the patient function? Can the patient speak, right? Go through the whole thing and make sure that the patient is nice and comfortable, right? Once the patient approves, right? Make sure you send this back to the lab, And the lab does a pretty good job of replicating the try-in, okay? Because if everything is good at the try-in, if the patient's happy, all they need to do is mill it in the final material, right? And so in this case, this is exactly what we did. We were, generally happy. The patient was generally happy with what it was, and the lab milled the final dentures, and sent it to us. And this was the final dentures that we got. The patient was particularly really happy. And again, this patient had 4 locators on the top and 2 locators on the bottom. And if you notice, the lab even made those holes for me, which was really nice. Big time saver for me. That way I don't need to go ahead, locate it, and then make my holes myself. All I needed to do was, put those white rings. I also place a little bit small piece of rubber dam to make sure that it doesn't lock in place. And then, yeah, you go ahead, pick the locators up, and yeah, that's it. The patient was very happy. And this was how the patient looked like at the end, right? So, these are dentures. There's a lot of things that you could do, right? But anyway, let's talk about how this whole process, how a digital denture basically compares to a conventional denture workflow, okay? So, first thing first, number of appointments, right? That's the big thing. The digital workflow takes about 3 appointments, okay? The conventional workflow, a minimum of 5 appointments if you get everything right, okay? In the digital workflow, you don't really need to, of course, you need a good impression, you need an accurate impression. However, you don't really need to make a posterior palatal seal. Because if you think about it, now think about it for a second, right? Why do you make a posterior palatal seal in a conventional denture? The prime reason you make a posterior palatal seal in a conventional denture is because you want to basically compensate for the shrinkage, right? Polymerization shrinkage when it's made. In a digital workflow, the denture is basically made from a puck that has already been polymerized, right? It's a pre-polymerized puck where the shrinkage, whatever shrinkage had to happen, has already happened, right? Once that's done, they go ahead and mill the denture out from that, right? So there is really no need to get a posterior palatal seal. That being said, it's really important to get a good, accurate impression. Okay, just because you don't need a posterior palatal seal doesn't mean that you don't need an accurate impression. You do need an accurate impression. Okay, um, possibility of procedural errors. Again, just a lot of moving parts in the conventional workflow. A lot of things, a lot of places you can go wrong, and so that basically adds to the possibility of getting more errors. Right? Again, it's like making, I don't know, a burger, a ready-made burger. You just put it in the microwave versus you go ahead and make a burger from scratch, right? The one that you put in the microwave that's ready-made will always taste the same, right? It'll be predictable. You know how it's going to taste. But the one that you're making from scratch, you don't really know how the final taste is going to be like, right? Every time there's something more, something less, less salt, more salt, whatever, right? And so the more number of moving parts there are in a workflow, the more possibility of getting a procedural error, right? Again, the lab cost, yes, given that it's a little higher with the digital. However, in my personal opinion, if I was saving on a couple appointments to give a product that was equally as good or better, I would go for it anytime, right? But that's just my personal opinion. Clinical cost and time, again, as I said, less number of appointments. You need lesser materials because most of it is coming from the lab, except possibly the impression materials. But yeah, apart from that, the general clinic cost and time required to make digital is much lesser, right? So, okay, once that's done, okay, we know that this is how we make a digital denture, okay? The thing is, where the rubber actually meets the rope, does it really work, right? Now, there have been multiple studies, right? So this study came out from Loma Linda, I believe, by Brian Goodacre in 2016, where they actually made like 40 dentures, 10 that were milled, 10 that were packed and pressed, then 10 that were poured as well, and 10 that were injection molded as well. Okay. Once that was done, they scanned the dentures, a certain, I think about 40 different points where where they measured all of the dentures. And once all of that was done, they basically, you know, concluded that the CAD CAM made dentures, right, was the most accurate fit, the most accurate adaptation to the tissues. The pack and press technique was the least reproducible for all of all the techniques, right? Now, the reason, just because of what I said, right? Just the things. There's a lot of moving parts, a lot of things you need to get conventional packing press dentures, right? A lot of places you can go wrong. Okay, so that's the way it adapts to the tissue. But is the retention really any better? Okay, there's any number of studies, right? There's so many. So just next year in 2017, the study came out by El Halal. I believe this was in the JPD, but anyway, they made 20 mill dentures and 20 conventional dentures. Um, they put like hooks on it, basically, or like rings, and place the patient near, like, it's a machine just like the Instron machine measures the amount of force. And what they found out was that the dentures that were fabricated by a milled process had much better retention as compared to the conventionally fabricated dentures. Okay. Now, if you remember, I said you can also print the dentures, right? At least the trial dentures, you can go ahead and print. So if you compare milling and printing, right? This study by Yoon in 2019, which was just last year, what they did was they compared these three processes, right? Regular conventional packing and processing versus milling versus 3D printing, right? And again, they used conventional materials and processes, like, they used the Hana varsity flasks for packing press, used a 5-axis mill for the milling the dentures, right? And they used DLP just like a sprint tray, right, to 3D print the dentures. And again, they measured it in a lot of different places. They measured in residual ridge crest, the hard palate, the posterior palate seal area, the mid palate suture area, just a lot of different positions. And what they found out was that you could actually use DLP, that's basically 3D printing, and the milling techniques for clinical purposes. So it should be clinically acceptable. However, it's really important to make sure that, you know, especially in areas, if you read the last conclusion, right, they were more likely to show intimate adaptation or mild impingement on the lingual slope of the mandible. And basically, if you read between the lines, what it is saying is that doesn't matter if your denture is conventionally processed or milled or 3D printed, right? Basic clinical skills like ascertaining where your high spots are. Is the denture rocking? Is the borders overextended? Right? Things like that. Just to be able to diagnose that and adjust the dentures accordingly. That basic skill is still very important, right? What the patients have to say about these dentures is that, um, of course, as a dentist, as a person who also works in the lab, could I make a better denture? Probably. Could I make a better looking denture, something that had more texture, more gingival festooning and shading and staining? Yes, of course. But does the patient want it, right? What makes the patient happy? So if you look at this study, right? This was a study by Bidra and group. I think this was from University of Connecticut, right? In Farmington, not wrong. But anyway, they had 20 patients. They used the same referential protocol, right? And patients were in general very happy, right? Again, they said that careful patient selection is also very important for this whole process. And yeah, but in general, the patients have been really happy, right? So, all of us know that we've heard this in just so many different places, right? the future of dentistry is digital. Digital dentistry is the future. Future is digital dentistry. The thing is, that future is right now. Digital dentistry is right now, right? So if you look at all the things that are on the screen right now, right? 3D printing, yes. Carbon came out with 3D printing, actually 3D printing Lucitone. Dentsply released the Lucitone material that is 3D printable recently. And you can do that right now, right? As long as you have a carbon 3D printer that's been FDA approved, you can do that right now, right? Then Avident has this monolithic denture thing wherein, this the one puck has both the white and the pink, and you go ahead and mill it out of the same puck. And so basically there's no teeth to bond to the base, and so there's no fault line in there, right? Also, um, Ivoclar has this puck wherein the white and the pink is again in the same disc. It's called Ivotion. Okay, all this is right now. This is not the future. This is not like, okay, in 10 years this is going to be that. No, it's right now, right? And you can do all this, right? What I see where digital dentistry or digital dentures is going is the basic ability to use face scans in treatment planning, right? In making wax ups or doing treatment, basically. Full arch scans, full arch implant scans, scanning the soft tissue. Systems are getting better. Um, Technology is getting better, right? So there's a lot to look forward to right now. And as I said, if you look around you, right, digital is everywhere. There's technology everywhere around you. It's like literally right in front of you right now, right? If you notice, digital is in everything, right? It's everywhere around you, right? So, let's embrace this and let's enjoy this whole journey together, okay? That's the main thing. If you had something to take away from today's lecture, I would say, be open to learning new things, be open to gaining new knowledge. Don't be afraid of trying out things. And while you're doing that, right, most important thing is to actually have fun, right? At the end of the day, it's just teeth. You know, yes, I understand we are all very passionate, really committed to what we do, but it's really important to enjoy, like relish what you're doing, right? Have fun, right? And involve the whole team, right? M- Make sure you have fun doing what you do, right? It's really important. Okay. So yeah, that's it. And we'll be opening up for questions soon. And again, this is my whole team. A special thanks to everybody that works with me to do what I do. And yeah, and thank you. Let's open to questions.
So if you click on the Q&A button
Mhm.
down at the bottom, you'll see a number of questions there for you. And you
Sweet.
can
All
click that.
right.
You can click
So
that answer live, and after you finished answering it, just click that it's been done, and the question will move out of the way for you.
excellent, excellent, excellent. All right. So the first question we have is that with Mesh Mixer, can you upload pictures of someone's smile and then alter it, or do you upload a scan of the cast? So in Mesh Mixer, what I do is you can upload a scan of the cast. Um, that'll be an STL file, right? Personally, I have tried to, if you use Blender, you can basically make a plane and then put the picture on that plane and make that 2D picture into a 3D and then import that in the Mesh Mixer. But for me, the best way is to use another software called Overlay, right? That's what I use to position the patient's picture on top of my cast and try to overlap those and then go ahead with my treatment planning or wax up for that specific case. With the Wagner Trine, what lab is this? We have an in-house lab, right? But mainly it comes from Avident. Okay. How would you modify your impression technique to accommodate an anterior flabby ridge or mobile tuberosities? Areas where in the traditional two-step impression technique, I place relief wax on the cast before making a final custom tray. So it's a very nice question. So just as I said, digital dentistry makes a good dentist better, right? However, it doesn't make a bad dentist to a good dentist. So it's really important to have basic clinical skills in place. And so what I would do is, alter the tray, okay, and make sure that I have more room in that area where the ridge is more flabby, right? And then basically capture that flabby area of the tissue in my wash material. Okay, just you would do just what you would do for a regular denture case. Can you take a digital scan using the prime scan of patients' soft tissues? No, no, you cannot. Right now, of all the systems that we have, scanning soft tissues is a problem because firstly, all that the scanner is doing is stitching different pieces of a picture together, just multiple pictures together. And so what it needs is in each picture to have certain points that are common between pictures so it can put it together. Problem with soft tissue is that soft tissue, whether if you're looking at it just one place of the mouth or the other place of the mouth, for the software to find any common points that are predictable, it's difficult for the software to do that. And so right now we do not have soft tissue scanning abilities. I mean, of course, you can take an impression and scan the impression. That's a different thing. However, to do that in the mouth, you cannot do that right now. Also, another problem with that process is that with regular impressions, you can do border molding, right? So you know where that junction between the movable and the immovable tissue or mucosa is. When you scan it, you cannot really ascertain where that junction is. And so, I'm pretty sure, companies might be working on that right now. So yeah, as of now, no. Why did you use rubber dam for picking up locators? So it's a good question, right? So a lot of times, when you have cases where the locators are long, what happens is the way the locators go into the implant, right? There's an inset, right? And so a lot of times, just the white ring by itself is not enough to block the excess acrylic from flowing underneath. And so it can actually end up locking up your denture in place, right? So to prevent that, what I do is I cut a small piece of a rubber dam, right? And I cut a small hole in it, and then place it on there first, then place my white ring, and then place my housing. That way I know for sure that my excess acrylic is not going to go ahead and flow underneath the locator and get locked. How comparable is the material when it comes to RPDs created digitally? Are the materials the same in that the strength of an RPD is similar when created digitally versus conventionally? Has there been any longitudinal studies on the durability of 3D printed dental materials? I think there have been studies. I'll need to look into that a little bit more. But right now, I haven't worked with too many, digitally designed RPDs. I know John Madden, amazing guy. He's been working with digitally planning and printing RPD frameworks with, I think it is acetate or something. But again, I haven't used it clinically for RPDs. I'm still sticking to metal frameworks, conventionally casted frameworks. Regarding denture stability of anatomic versus flat playing teeth, digitally fabricated. Mm, regarding denture stability of anatomic versus flat plane teeth digitally fabricated. Well, okay, I get what the question is. So basically what I do is, for my conventional dentures, I think this is a paper by Ortman, right? Um, you look at the ridge and you make sure you see how much of lateral stability the ridge has. And that way I go ahead and, make a decision of using either anatomic anatomic teeth or my flat plane teeth. If the patient does not have a good ridge where it can give me a lot of lateral stability, I would stick to monoplane teeth. However, if the patient has a good, nice, tall ridge where I know that, even when it's guiding in eccentric, the denture is not going to be displaced laterally. That's when I can go for more lingualized or anatomic teeth. Okay. Generally, with Avident, you have a choice of either going monoplane or lingualized. Okay. So you take an analog impression and lab scan it or intraoral scan the upper and the lower. I do a conventional impression of the upper and the lower and then scan it in the lab. Okay, you cannot scan the upper and the lower tissue as of now. Does Prime Scan have the capability to do wax ups? I believe it does. For now, I'm working with the Omnicam. I haven't had too much experience with Prime Scan as of yet. But yeah, I've been doing it on the Omnicam. I've had no problems as such. The only thing is you need a license to export that. And a lot of times they don't let you export the wax ups. So, for me, it has been sometimes a bigger headache working with that. Doing my wax ups in the Omnicam that way. And so a lot of times I just do it on Mesh Mixer or John does it on Exocad or the 3Shape Design Studio. Okay. Is it possible to scan an existing CD that a patient is very happy with the fit and can be replicated to the thickness of the acrylic peripheral roll extension? Yes, you can actually do that. You can, if the patient is particularly happy with present denture, you can go ahead and also scan that and you can have an exact fit. Okay. Have you had to reline the Wagner trine in the second appointment ever? Yes. I've had to. So you can also do that in the second appointment. And almost about 1 or 2% of my cases, I've had to do that. But yes, I've had to do that. Okay. If there's been, a delay in pouring up or actually scanning, sorry, not pouring up, in scanning my impressions, my initial impressions, or, something's gone wrong where the fit is not as expected, you can always go ahead, trim down the intaglio of the Wagner trine and do a quick wash and go ahead from there, right? The lab actually scans the whole thing, both the intaglio and the cameo, and designs the denture from there. So yeah, that should work. Which digital denture system is the most predictable? The system that works well in your hands is the most predictable, is what I would say, right? So go ahead, try out different things. There's many ways to do a thing, right? There is, for the digital denture market, there's Avident, Denka, Ivoclar, a lot of ways you can do it, okay? Try them out, make one denture with one system, another denture with another system, see which workflow works for you better, right? Because for predictability is different for different people. In my hands, Avident has worked really great. But again, that's me. It could be something different in your hands. So my suggestion would be go ahead and try it out. Try out different systems. How about the use of digital dentistry in partial dentures? Yes, you could do it, and we have some amazing people that are doing it right now. John Madden and his lab, they are doing it as well. Again, I do not use a lot of digitally, milled or printed dentures as of yet. But yeah, I mean, it's one way of doing it, definitely. If the denture is loose during trying, can you take a wash impression? Yes, you can. Yes, you definitely can. And I would recommend doing that. Okay. Um, what questions do you ask the patient to help you plan treatment and address expectations? A very good question. Very good question. So generally, I let the patient know that, okay, um, there's many ways of doing a thing. We could also do it conventionally. That would be 5 appointments. We could do it digitally. That would be 3 appointments. And basically just get an idea of what the patient is looking for. Educate the patient, right, with all the treatment plan options. Let the patient know that you're not there to sell the patient something, right? Every time I meet a new patient, I tell the patient, hey, don't consider me as like a car salesman. I'm not a dental salesman, right? Think of me as a friend you met at the bar, who just happens to know a little bit more about dentistry. That's it. And let's see what dentistry has to offer you, right? It's not me, it's dentistry. Let's see what dentistry has to offer to you, right? So that's the way I approach the patient, right? That way patient's a lot more open. I can get a lot more information out of the patient about what he wants, what he or she wants, what they're looking for. And yeah, that these would be the questions I would ask the patient. So to go straight to the final impression, are the thermo trays the best option? Yes. Yes, I would say that. Why? Because these trays you can adapt to the tissues, you can adapt to the arch, you can adjust those. And once you're done doing that, you can go ahead, place a little bit of material in the middle just to act as a spacer. Because with PVS, you generally want about 2 to 3 millimeters of material to make sure that, when it sets evenly. And so there's no dimensional distortion while it sets, right? So yeah, for me, the thermoplastic trays have been really good. Um, the last question here is, do you use impression adhesive on the tray and also in between border molding and the wash? I use it initially when I do my border molding. However, once I have a base layer of material, after that, I do not use any adhesive because PVS bonds to PVS and bonds pretty predictably. And so generally, it's not a problem. So for my first addition of the material, I would add adhesive, but after that, I don't need any extra adhesive. All right, so yeah. Another question. As you know, in several cases, we need to adjust the teeth from beneath for setting them. Yes, that's true. How do we transfer this kind of information to the software? So basically, a lot of times, you do this with conventional protocols. You don't need to do this with the digital protocol because the software is already doing that for you. So unless, if you were printing or milling the case yourself where you're using teeth from a specific card, you could make a tooth reduction guide, or you can print that, and then that way you know how much of the teeth to reduce from the intaglio surface, and then set it into the denture. But that's only if you are printing your own dentures or milling your own dentures and using carded teeth. So that's a very special scenario. But in general, to communicate that to the lab, generally it's not a problem, because to the lab, all that the software needs to know is where the incisal or the occlusal plane needs to be. And once it's milled, it's milled in the miller. So yeah, it's already taken care of. For mill dentures, do you usually need to do a clinical remount? Ideally, the ideal method of delivering dentures is to always do a clinical remount. That being said, in clinical practice, the occlusion has been really close. So a lot of times I have not needed to do it, but uh, if you ask me as a prosthodontist, the ideal way to deliver dentures is to always do a clinical remount after a lab remount has been done in the lab. So that way, there are not a lot of adjustments you need to do on the delivery appointment. And yeah, for mill dentures, I've not needed to do too many clinical remounts. No. What is the probability of a patient breaking a denture or popping out a tooth? How can we fix it? Amazing question. So, if you do a monolithic dentures where the white and the pink portion is basically part of the same puck, I've never had a tooth actually pop out because it's essentially the same material and it's all bonded together. Um, However, if you had to use carded teeth, right, into that denture, which you can always do, if the teeth actually pops out, you can put it back in just the way you would do it with a regular denture. So it's the same material. It's PMMA. You could use cold cure acrylic to go ahead, make your grooves, use some cold cure acrylic, put it back in there, press it in place, put it in a pressure pot for whatever, 10, 15, 20 minutes, make sure it sets and adjust it, finish it, make sure it sets, and that's it. So it'll be in there. It'll be in place. No problem. Okay, so yeah, any more questions? Excellent, excellent. So there are no more questions, and yeah, let me know if there's anything you guys need. You guys can, feel free to email me. Let me know, and yeah, it was nice meeting everybody. I hope you guys have a nice day. Thank you, Joe. Thank you, William. Thank you, Sai, for setting the whole thing up. It was a pleasure speaking to you all. Thank you. Bye bye. Have a nice day.